People think, oh, how could food be that powerful to heal some really serious condition? But it turns out that it really is this very specific diet. Ketones do not need an insulin signal to get into a neuron. They just float right in. And so that's the main benefit here, is that we don't need an insulin signal. And yet the ketogenic diet completely changed the course of their severe mental health condition, things like bipolar diagnosis or schizoaffective disorder diagnosis, things that medications have a hard time treating. And these people have tried, sometimes say, I feel 20 years younger than I did 5 years ago before I started this.
Welcome to Medicine Redefined. I'm Dr. Altamash Raja.
And I'm Dr. Darsh Shah. Let's put the health back in healthcare.
Quick update before we dive in. I'm now seeing patients through my telemedicine practice, refining health and performance. It's built around health span, longevity, and performance using the Medicine 3.0 approach we talk about on this show. I'm opening a limited number of founding member spots. If you want to work together, go to refininghealthrx.com. All right, let's get into the episode. Matt, welcome back to this part two. A lot of exciting things that we talked about in the first part. And for those really just catching up, I'd advise you guys to go back and check out that first part of the discussion, because I think it's important for us to get an understanding of why it is that we're even having this conversation. So that part of these quote unquote mental health issues, and really just reframing how we approach this primarily symptom-based management strategy that we have, actually see where we can apply biology and make it more synonymous with our approach in a lot of the other fields in medicine. So I kind of want to pick it off right where we left off. We spent a lot of time talking about the role of insulin resistance in mental ill health, I'll say. And you touched on something important. You touched on the ketogenic diet a couple of times and its powerful role. Now, the ketogenic diet is really interesting. Darsh and I have talked about this from a cognitive perspective and its benefits in that. My wife is a neurologist, and so we understand the role. In fact, she's an epileptologist. So with its role in seizures and refractory seizure stuff, that's been mentioned for decades at this point. But the psychiatric component is something that I don't think is talked about as often. So where does it make sense for us to start? Does it even make sense to, I'd actually be interested to look at or understand your perspective on how you define ketosis, what that is. You did mention there's a certain marker that you trace. So where do you want to take it off?
Sure. Yeah. Let's talk about ketogenic diets, because it's really exciting, actually. It's like, it's a diet. People think, oh, how could food be that powerful to heal some really serious condition? But it turns out that it really is this very specific diet. So we got to get into the details a little bit. So a ketogenic diet is eating most of your calories from fat, moderate amount of protein, and very little of calories come from carbohydrates. So, that's really important. It's people think ketogenic diet and they think, oh, high protein diet, you're eating protein all day. That's actually not going to put you into ketosis. You actually have to eat most of the calories from fat. When they first invented this diet for kids with epilepsy, they were using a very high ratio of fat to protein and carbohydrate. It was a 4-to-1 ratio. So literally 90% of the calories were coming from fat. And we've learned over the years that that's not necessary. We don't need to have it be that extreme. So we can do more like a 1.5-to-1 ratio of grams of fat compared to grams of protein and carbohydrates. Maybe a 2-to-1 ratio for some people who are not reaching enough ketones with the 1.5-to-1. But typically we start people at 1.5-to-1 and we can get a good enough level of ketones. And it's a biomarker that we can actually measure in mental health, where I'm prescribing medications and I have no biomarker to follow at all. I can't test the blood to find out if the medication's working. I can't check to see if there's enough blood levels of medication. Whereas this, we can follow it really well, and it really tracks very nicely with clinical response. And so it's an easy test. People can get one of these machines. Similar, it looks like when someone's checking their blood sugar, they prick their finger and we put the little drop of blood on a little strip and we put it in the machine, and we can get a level of beta hydroxybutyrate, which is one of the most important ketones. And if our level is above 0.5, that's considered clinical ketosis. Usually for mental health, we're targeting levels of above 1 or 1.5 and anywhere up to 4 or so. So we have a nice range there where we know there's a nice therapeutic effect. and people do really well in that range. And so we really can see, is the intervention we're trying to do creating the right biological response that should then correlate to a good clinical response, which again, like I was saying, we just don't have that in the rest of mental health, unfortunately.
So the floor for you is 1. And is it this? Okay.
Typically, and I should mention too that the ketone levels do fluctuate throughout the day.
Mm-hmm.
And so they're usually lowest right in the morning as someone's waking up. They have that dawn effect with a lot of elevated cortisol that will suppress ketones right initially. And so if they're checking first thing in the morning, we're not going to get levels of 1.5 or 2 most likely. Usually the levels are lower. But when I say 1 or 1.5, we're usually checking late afternoon or early evening after dinner. And usually that's when we get a nice level. The levels actually keep rising all through the night, and they're actually at their maximum at about 3 or 4 in the morning before the cortisol spike that's coming for waking up. And so we actually have access sometimes to continuous ketone monitors, and I've seen someone's traces, which are really interesting because you can see them in the morning. This person's were often around 0.3, 0.4. In the middle of the night, they were often up to 4. And so if you check them at around dinner time, they were maybe 1.5 or 2, but, and that was great. This person was having a wonderful clinical response to a serious mental illness. But if we checked him in the morning, you would think, oh, he's not making many ketones. But it turns out there's really quite a bit of variation throughout the 24-hour cycle.
I was recently revisiting this topic, as I mentioned, and initially I had thought that you have to be at 1 to be clinically in ketosis. And then I came across some work of other people who said that technically actually even 0.5 and above technically push you that. But what you're saying is this is more for the benefits exclusively from a psychological health perspective. Is that what you're saying?
Yeah, that's what I'm saying. Technically above 0.5 is considered clinical ketosis or medical ketosis. But just in general, for most people are coming at this to try to treat a more serious mental health condition, we'd like to get it higher than that in the late afternoon or evening. Caveat being, if you're checking in the morning, 0.5 might be great. That might be plenty. And you wouldn't want to necessarily go higher if it's first thing in the morning.
Is there a problem with being in 6 or 7 in that range?
It's not dangerous unless someone is taking insulin or is a type 1 diabetic. And then we'd be worried that they're moving into some kind of diabetic ketoacidosis. But there's a lot of feedback mechanisms that will prevent someone who's not a type 1 diabetic from going into ketoacidosis. And so usually they get up really high like that. And there's these self-limiting mechanisms that'll bring it back down. In fact, if the ketones get high enough, you actually make an insulin response. If you're able to make insulin, and that will naturally bring the ketones back down. So there's sort of a feedback mechanism that protects you. So, some people do get them up that high. I've seen them up around in the 7 range. It's not dangerous, but I think it's not ideal for functioning and feeling at one's best usually.
Right. More isn't necessarily better in this case.
Yeah, that's right.
You had mentioned that the brain is roughly 2% of body weight, consumes more than 20% of energy or even glucose.
Right.
And so it's a very energy hungry organ.
Correct.
And glucose is one of the main resources, ketone, of course, being the other one. Can you speak a little bit about mechanistically why ketones are better fuel for the brain? And with respect to these psychological diagnoses, I know that we're kind of trying to bucket them into bipolar and just for the purposes of studying this stuff. Which specific phenotypes seem to respond best to that intervention?
Yeah, two great questions. Let me take the first one first. So the fuel to these neurons, and mostly we're talking about neurons here. These are the main cells in the brain that are communicating information. They're supported by all these other types of neurons as well. But let's think about neurons. They become insulin resistant. This is why we care so much about insulin resistance. And we know that all mental health conditions, most neurological conditions, have brain insulin resistance as one of the main features. So we know that exists. And what that means is that there can be glucose surrounding that neuron, but the glucose can't get in to be used as fuel because it needs an insulin signal to get glucose into the cell. And we can't get that insulin signal if there's insulin resistance. Ketones do not need an insulin signal to get into a neuron. They just float right in. And so that's the main benefit here, is that we don't need an insulin signal. And so there's constantly, if you have ketones around, we never will have that neuron go into an energy deficit because of insulin resistance, which is happening, we think, all the time in these mental health conditions. And so that's this idea that we now have this additional source of fuel. It doesn't require an insulin signal, and it will always be able to make up for the deficit that might be there for that neuron if it was just relying on glucose. So that's really important. The other important part about this is that ketones are a cleaner burning fuel than glucose. And so we're going to create less oxidative stress and therefore less neuroinflammation. And so this is also very, very important in terms of, as a fuel source, this is a preferable fuel source. Maybe let's stop there and see if there's any questions about that, because there's a lot to that. I already just said, yeah.
Yeah, no, I have some follow-up questions regarding adherence. And I also wanted to talk about the protein aspect that you mentioned, but let me let me just go ahead and do that now, right? So one of the things is we recognize that adherence is very difficult. So you said a lot of fat, very low to nearly no carbohydrate. And this is another interesting thing. I have conversations with patients, with people, and they'd say, oh, I'm on a no carbohydrate diet. And when you ask them really what they're eating, they're not counting the carbohydrates that's in fruit and vegetables. They're not counting carbohydrates. You have carbs and all these things.
Right.
And that's very different than being on a true ketogenic diet. I think for the average person, probably you're going to need to be less than 50 grams of carbohydrates a day, which if you're eating a lot of veggies, you can get there pretty quickly.
Yeah.
So there will be some people who will talk about net carbohydrate, and I'm kind of curious where you stand there. What my thing with this has been, and like I said, this is something that I've really thought about getting into, even exogenous ketones from a cognitive perspective, from being sharper, especially like when we're doing this later in the day when I don't want to use caffeine. The thing is the reducing protein intake. So Darsh and I, we're fascinated, we're physiatrists, we're really recognize that age-related muscle loss is inevitable, and we want to hold on to that as much as possible. And for context for you, I'll tell you, like, I had a surgery nearly 19, 20 months ago. And after that, and being immobilized for lower extremity for some time, I lost nearly 17, 18 pounds of lean body mass. And so when it comes to insulin sensitivity, when it comes to creating a metabolic sink in our body, muscle is the greatest tissue that we have. We know this, right? And so it's a bit of a catch-22 when you're not feeding that muscle, we're not laying down that protein to get those building blocks, especially if you're training and you need to be in an anabolic state, you need to be in a repair state. And then as we start getting anabolic resistance, is how do you balance that? How do you think about that aspect of it with respect to like not getting somebody to gluconeogenesis?
Yeah, great question. And I agree 100% about the importance of skeletal muscle for longevity. It's so important actually for mental health as well. And so I'm constantly asking people to do resistance training. It's actually the form of exercise that's the most beneficial for depression is resistance training. Far outperforms aerobic training, in fact. So big believer in building muscle as well. And what I'm talking about is not a low protein diet. Just to be clear, I'm just saying we can't go, crazy with protein. So the RDA says 0.8 grams per kilogram of protein per pound per day. And that's too low for almost everyone. And so, some people who are really in the fitness world, people who are trying to build tons of muscle will go way higher than that. They'll go up to 2 or even 3 grams per kilogram of body weight per day. And that would be too much to produce ketones. And so what I'm talking about is some moderate, so something in the middle here. And so for most people, that's like 1.2 to 1.6 grams per kilogram of body weight. And that's sufficient to build muscle for sure. It's not going to optimize muscle building. Like if someone's trying to become Mr. Olympia and bodybuild, they're going to say 1.6 is not enough for me. And I say, that's fine. We just won't be able to produce ketones. We got to choose some things sometimes. But for most people who are just trying to be healthy as they can, live as long as they can, and they're really if they're in the gym working out, they're going to be able to make ketones at 1.6 grams per kilogram, no problem. And for the person who's not training that hard, 1.2 is probably adequate and they'll still be able to make ketones there. So that's kind of my range for producing enough to build muscle, but also enough to be in ketosis. So yeah, that's really important. I'm glad you brought that up.
Yeah, Matt, I keep coming back to this chicken or egg question, right? So I'm assuming we don't have the studies. I mean, so when we talk about ketogenic diets, we're talking about from a treatment point of view, right?
Correct. Yeah.
Do we have the research to talk about it maybe from a more prophylactic point of view? Because, a lot of these podcasts I listen to, Tim Ferriss, for example, he has a strong Alzheimer's predisposition from his family. So he talks about going keto now, but do we know that you actually have to have, metabolic dysfunction, insulin resistance, then use a ketogenic diet to kind of bypass that, to kind of, give the brain a different type of fuel to work better? Or can we actually just start with the ketogenic diet outright and prevent these diseases from occurring?
I think we're just not there in terms of proof for prevention at this point. However, I similarly believe that there should be a preventative effect given what we know about these mechanisms. And if someone was at high risk, I would certainly advise them that this is potentially very helpful for them in terms of prevention. We see it in dementia, in mild cognitive impairment. There's definitely the ability to reverse some mild cognitive impairment with a ketogenic diet. Once someone is already at the point of, dementia diagnosis, it's probably too late at that point. We've lost too many neurons at that point. You're not going to bring back neurons that you've already lost. And so that's one way to look at it. The other way to look at it is, think about the extrapolation from the epilepsy world. We're talking about young kids, and those kids haven't developed severe metabolic dysfunction yet their brain is, having seizures, right? And we know the ketogenic diet can treat that. And so we don't have to think about this only in the context of severe metabolic dysfunction. We can think about it as this is simply is with epilepsy. And now we're seeing it in people, young people that I see in their 20s. Some of them, their blood work looks just fine from a metabolic point of view. Their HOMA-IR looks great, and they don't look like they have any insulin resistance on their blood work. And yet the ketogenic diet can completely change the course of their severe mental health condition. Things like, bipolar diagnosis or schizoaffective disorder diagnosis, things that medications have a hard time treating. And these people have tried multiple medications, not gotten benefit, and then they get benefit from a ketogenic diet. And so we don't have to think about it just in the context of severe metabolic dysfunction. This diet seems to really improve brain health. And that's where we have to think about another mechanism, which is that these ketones are a signaling molecule to mitochondria. And so that's really exciting as well. So we have this, additional source of fuel mechanisms, but we also have the mitochondrial mechanisms that really, could also be just as important. We don't really know yet. The science is not out on which one's more important. They're probably both important. But we don't have to just think about this for severe metabolic dysfunction.
So coming back to the phenotypes that respond best from a treatment perspective.
Yeah.
Depression, anxiety, bipolar. What are we thinking?
So I've seen the most dramatic results in more serious mental illnesses. And these are people who are the most motivated in some ways because they've already been through multiple hospitalizations, multiple medications, and the medications they're now being prescribed are usually a cocktail of 3 to 6 medications that are causing them pretty severe side effects. They don't like the way they feel on these medications. When they've tried to come off of them, they've often ended up back in hospitals or with more severe symptoms. These people are very motivated, and I've seen the diet be extremely helpful in those folks. And we now have a number of pilot trials and case series of people with serious mental illnesses. Probably the one that's been studied the most is bipolar disorder. And that, to some extent, makes some sense that if it's really good for epilepsy, there's a lot of overlap between epilepsy and bipolar disorder in terms of the phenomenology, the mechanisms, but also the types of medications that are used. Most of the medications we use in bipolar disorder are anti-epileptic drugs. We've seen that over the years. And so, there's a lot of reason to think that this would be, a condition where it would be very helpful. And it turns out that it's the one that investigators have chosen to study the most. And so we have a lot of good data in bipolar disorder. But we're seeing data in, like I said, psychotic disorders like schizophrenia and schizoaffective disorder, severe treatment-resistant depression. We're seeing data in severe OCD. And people ask me, would it work for my ADHD or anxiety disorder, yes. In fact, you may not even need to get as high a level of ketones for it to work for that. We could shoot for even a lower level of ketosis, and something like ADHD or mild to moderate anxiety, mild to moderate depression would be fairly easy to treat with even a lower level of ketones.
I think the other thing that I've come to learn is, right, it's not either utilizing glucose all the time or ketone all the time, right? Metabolic flexibility is a phrase that seems to be very important when you're just talking about health in general. And so the Glucose-Ketone Index is also something, is my understanding. Is that something that you pay attention to, or if so, like, how do you use that in your practice?
Yeah. So the Glucose-Ketone Index is an interesting thing because essentially it is looking at how much of the fuel is coming from glucose versus how much is coming from ketones. And so the lower the index, the lower that ratio, the better. This has mostly been used in investigators who are studying ketogenic diets for cancer, actually, where it's also been studied quite a bit. And there does seem to be a really important use for it there because in cancer, we're trying to not only provide ketones, but we're really trying to starve these cancer cells of glucose. And so the lower the glucose, the higher the ketones, the better this intervention is going to work in cancer. We don't have that same level of data in brain health at this point. And so we're not typically using GKI, although it may turn out that it is something that we should be paying attention to. But so far, at least, we're looking at trying to just get those ketone levels up higher. And typically when you're doing that, the glucose levels are also getting much lower. And like I said, for some people, we're starting out that they're not metabolically unhealthy anyway. So, I typically put continuous glucose monitors on all the people who come into my program. And it's very common that the glucoses will just be flat. And we just see them, between about 70 and 85, and they don't go anywhere, eating a ketogenic diet. They don't go higher. Occasionally they'll go a little bit lower when people are first transitioning in. But once people are adapted to it, it's almost like a flat line, the glucose curves. And so it's really more, we're just thinking about how high we're getting the ketones at that point. The glucose isn't going up or down very much.
Yeah. Have you ever personally experimented with the ketogenic diet?
Oh, yeah. In fact, before I prescribed it for anyone, I put myself on a ketogenic diet. And that was about 5 years ago. And I've been in a low level of ketosis ever since then. I pretty much do it continuously. I'm not shooting for high levels of ketones. I sort of shoot for about between 0.5 and 0.8 or so. That's where I typically am based on how I eat. And I love it. I sometimes say I feel 20 years younger than I did 5 years ago before I started this. Yeah. Really keeps you feeling young and energetic. I can do way more in the gym. I can do way more work throughout the day without it feeling challenging. I don't have to worry about, eating if I don't have something I want to eat, or if I'm traveling and there's nothing good to eat. I have that metabolic flexibility. I can just skip a meal. Before I did this, I was definitely insulin resistant. I could never skip a meal. In fact, I used to eat snacks in between my meals so I could keep my glucose up. And it's really been liberating from that point of view as well. Yeah.
What about the use of exogenous ketones?
Yeah, it's a great question. And there's a lot of interest in developing exogenous ketones. And it makes sense to me in some ways, because it's very hard to get people to do this diet, and especially people with dementia or more severe mental health disorders. This might be very challenging to organize. There may not be a setting where it can be done, or there may not be good enough executive functioning. And my sense is that we can get some benefits from exogenous ketones, but not nearly all the benefits that we're getting from a ketogenic diet. I don't think we'll ever be able to truly reproduce all of these benefits with exogenous ketones. And there's two reasons for that. One is that we can't keep the ketone levels up all day long, all throughout the 24-hour cycle using exogenous ketones. The longest that some of these products may last is about 4 hours or so. And so you have to dose them, probably 3 times a day at least, to keep the ketones up during the daytime. And then overnight, they're going to go back down again. So we will get some of the benefits of the signal that ketones give to the mitochondria. We'll get that benefit. We'll get some benefits in terms of this additional source of fuel at times during the day. But what we're not going to get, and this is sort of the second reason, is that we're not going to get that reversal of insulin resistance. We're not going to get that, reduction of insulin and all those other fundamental metabolic changes that you're getting by removing carbohydrates from the diet. And I shouldn't say remove. And you were asking some questions before about what people can eat. We should get into that a little bit because, it's not as strict as, in a 1.5 to 1 ratio. People definitely can eat a lot of non-starchy vegetables, and they even can have some berries, some fruit, and still keep themselves in a state of ketosis.
Yeah, this is getting me thinking. I need to start fasting. Getting back to my 24 to 36 hour monk fast once a week. I did enjoy those. But when you say prescribing the ketogenic diet, how do you actually apply that to your patients? Now, I'm assuming it's patient specific, but is there something that you usually tell them to quick start, whether it's a fast or certain foods? How do you get your patients to implement this diet?
So, yeah, it really depends on the setting and the person. So if it's just in an outpatient setting and I'm not working with a dietitian, it's just me and that person and I'm counseling them, I often will start them off just by, let's just start with a whole foods diet. Can you do that? Let's just remove as much ultra processed food and severely processed food as we can. Then we'll say, let's cut out other sources of sugar if we can at that point. Once we get to there, let's cut out some starchy vegetables. Let's cut out bread. Let's cut out rice. And then we're pretty much there. Then we have to add in fat. We have to remove people's fear of fat at that point. We've all been taught that fat is dangerous. Fat's going to give us heart disease. We have to reduce it. We have to remove it, or fat is going to make us fat. All these things are not true, but everyone is walking around with all of those ideas in their mind. And so we have to relearn what fat does and how it works and not to fear it. And then, so once we're there, then we can start thinking about macronutrients. So we want to get their carbohydrates down to about 30 grams of carbohydrates per day or less for most people. And we want to figure out how much protein that person needs in that 1.2 gram per kilogram or 1.6 gram per kilogram range, get a sense of that. And then essentially, if the person is fairly healthy and active, we can just say, eat fat to satiety, basically. So if you're still hungry, eat more fat at that point. If you're not hungry, you don't have to keep eating fat. And if someone's carrying around some extra body weight, especially some fat, they can make ketones out of their own fat. And so if they're eating a little bit less and they're in ketosis, they're not that hungry, I don't force them to keep eating more fat, and they can make ketones out of their own fat. Once someone gets down to a normal weight and they have a low amount of body fat, they're going to need to add back in eating some fat at that point. And then usually we're kind of good from there. But the way I just described it, that's someone who's got good executive functioning, is observant, can make changes in their life. And so different settings may require a lot more support than that, depending on the person.
I love this. I mentioned to Darsh just because I find myself as somebody who does well on somewhere between 150 to 200 grams of carbs a day. But there are times in life where you just something keep coming up over and over and over again in different contexts. So I just think this is all the sign pointing that I do have to try. I'm actually looking at the Keto Mojo right now. At the very least, maybe I'll start with the Glucose-Ketone Index to see where I'm at and how much I need to do to get to that 1.5, kind of where you are. I love how we're walking down the lifestyle medicine pathway, quote unquote. I think it's necessary. It should be the foundation as opposed to putting it toward the very end. So let's keep walking down this pathway. Do you think there's anything else within the nutritional realm that we need to explore with respect to this, or did we cover most of it?
I think we covered most of it. I just want to point out just the one quick question you had about net carbs. Oh, yeah. So this is really important because net carbs is calculated by taking the carbohydrates and kind of subtracting fiber from that and calling it net carbs. And people can definitely get into trouble in terms of, being able to achieve ketosis if they're just focused on net carbs, especially if they're eating packaged foods that have, they say, low net carbs. And you look at it and you see, well, there's actually quite a lot of carbohydrate in there, because some of those net carbs or some of those carbs that, are actually digestible, and not all fiber is the same. There's many different types of fiber. And so we're fine subtracting the carbohydrates in vegetables, because the carbohydrate there is really not digestible at all. And so that's fine. But there are these other fibers that they put in these packaged foods. And so you have to be careful, because a lot of those actually are digestible fibers. And so there's a whole industry now of keto food you can buy at the store, keto cereal, keto granola. You just have to be a bit careful about just focusing on just the net carbs and things like that.
Yeah, that's a good point. Thank you. So after nutrition, we talked a little bit about the role of resistance training, exercise, other pillars that when I look at that, of course, sleep. We've talked about the importance of that. And if I'm just going down the lifestyle medicine thing, I'll just use the American College of Lifestyle Medicine. They talk about refraining from exogenous substances. I won't use stress because that's kind of the main lens that we're looking at it within the psychiatric illnesses, I suppose. Where does the literature point to with the best evidence for these mental health conditions that we've been talking about?
I'm sorry, can you repeat that? The best evidence for what exactly?
Well, assuming like we've talked about nutrition afterwards.
Yeah.
Is it exercise? Are we talking about, where would you go next with a person if you're prioritizing by the state of the evidence after nutrition?
Yeah, great question. So absolutely exercise. There is absolutely an enormous literature on exercise and mental health. It's incontrovertible that exercise is very effective for things like depression, anxiety, ADHD, so many of the psychiatric disorders respond beautifully well to exercise. And we have, meta-analyses that have, more than 1,000 research articles in the meta-analysis. We're not talking about just a little bit of evidence here. We're talking about huge amounts of good quality evidence. The problem with, just saying to people, you've got depression, go exercise, is that they really have a hard time doing it once they're depressed, right? And their diet's going to be working against them. And it's a really powerful tool, and it's really synergistic with the ketogenic diet or a low carbohydrate diet in terms of improving brain health and mental health, because many of the same mechanisms by which exercise improves mental health are the same ones in which we were describing ketogenic diets: reversing insulin resistance, increasing BDNF, lowering inflammation, and improving mitochondrial health. All of that is achieved through exercise and ketogenic diets. So there's tons of overlap and synergy there. And so that's definitely where I would go next. And, combination of different types of exercise, aerobic and resistance training, throw in some, sort of mind body kind of exercise like yoga or Tai Chi in there, if they're able to do that. All of those things have their own unique benefits for brain health and mental health.
What's the program look like at Accord when they're coming for like 4 weeks at a time, that intensive? What's the exercise prescription look like there?
So we have a personal trainer that we work with, who we send people to twice a week. And he's often getting people restarted or started for the first time on an exercise program, that, hopefully they're learning about how to do this and how to continue it when they leave. That's the idea. And it can be different for different people. I mean, sometimes he's starting really basic and, but some people have an exercise history and he can go a little more advanced. We're also getting people walking a few times a day, every day at the program for multiple reasons. One is that, we're talking about glucose disposal before. When you use muscles after a meal, whether, no matter how many carbohydrates you had, whether a small amount or a large amount, that glucose is going to get disposed of mostly in the muscle. And if you're moving those muscles, there's this GLUT4 transporter that comes to the surface that will bring glucose into the muscle without needing insulin. So we get glucose disposal without insulin if you walk after a meal. So that's a really important thing for people to start practicing. And once they're doing it and getting in a habit of it, hopefully they continue that throughout their lifetime, because that has tremendous long-term benefits. And so, it's usually the combination of the walking and, a couple times a week with the trainer. And then if we get people really interested, we're trying to get them to go to the gym at other times during the week as well. And we've had a number of people who have started to do that. And the more someone exercises, the more benefits we see typically within the program.
I love it. Yeah. Especially the piece about resistance training being even more important, right? I think that there's a lot of attention appropriately paid to the value of steady state, low intensity exercise. Some people call it zone 2, whatever zone you want to call it. However, when we just look at the literature, it actually turns out that resistance training is probably more beneficial, not from a mental health perspective alone, but also just healthy aging and downstream, muscle loss, things that we talked about, and just longevity in general. So when you think about health span, I think that's probably more important. It's all important. We're not saying one is necessarily more important, but actually, I guess we are saying that. Or at least I am.
Can I ask?
Yeah, go ahead.
Real quick. Matt, when we look at exercise, what are the endpoints that we're looking at? Like, are these self-reported symptoms that we find that are improving, or is there a specific, I mean, obviously the metabolic markers I'm sure are, but what else are you really looking at?
Typically in these research studies that I was referencing, they're looking at mental health rating scales. So they're looking at like reduction of depression on a HAM-D or a MADRS or a PSQ-9 or something like that. We're talking about symptom rating scales typically that they're using as endpoints. There's probably better measures than that, but that's typically what they use. Yeah, in those studies. Yeah.
Gotcha. Yeah, I'm curious just because, like, I mean, when I go work out or, somebody gets more aesthetically in shape, you might see more opportunity or see themselves fit in the world better and have more agency to kind of do the things that they want to do. So curious to kind of see, is it a direct correlation or is it more of kind of just, when you start to exercise, when you start to get maybe that self-confidence, you start to kind of see the world differently, so to speak.
Absolutely. I think that effect is real, but I don't think that that's usually what they're measuring in these studies, which are a little more short term. So we get the direct effect and then we get all these other ancillary effects as well. I think we get it all when we exercise. If there was one thing that we get people to do for their health, period, it would be exercise for sure. And then I think we shouldn't also leave out high intensity training too, which has its own unique set of benefits. And especially for people who are busy, if you can get people to do some high intensity training, huge benefits in a short amount of time. Usually we can't start people there because we don't want to injure people. If they're really just starting their fitness journey, we can't get them to do a really serious high intensity interval training workout. But the evidence for that is tremendous. And I think there was a paper that just came out that showed that typically people think of high intensity as sort of twice as effective as moderate intensity, but now it's like seen to be like 10 times more effective than moderate intensity, which is really music to my ears because I like to be efficient at the gym and I like to just really go hard for a shorter amount of time. And there's really now evidence showing that there's real science behind more benefits in a shorter amount of time.
Yeah. I wonder if we're thinking about the same one. I think Patrick recently had a Journal Club episode on this. It might have been a paper in Nature if that's the one you're thinking about.
Yeah.
So we'll find that and we'll link it. Yeah, it was really mind-blowing talking about how maybe 1 minute of high intensity interval training was equivalent to like over 150 minutes of walking or something like that with respect to specific metabolic ill health dysfunction types things, right? So metabolic resistance stuff. So that was really fascinating. I want to switch to drugs now. Let's talk about some pharmacology again.
Sure.
In research or while preparing for this, I came to realize that, or at least came across some evidence that actually looking at some of these diabetes drugs as mood tools.
Right.
And essentially talking about how insulin sensitizing and incretin-based therapies can improve mood in some patients. And, it was interesting there, some of the mechanistic stuff looking at inflammation, energy signaling pathways, things that we've talked about in the first half of this discussion, not just glucose lowering systemically. So I want to kind of get your understanding and how you prescribe them, if ever. Do you ever use these, I guess, off-label for, like a mental health condition?
So I have prescribed them some, and, I think there's a couple of contexts where it makes sense. One is in someone with a serious mental illness who has been on psychiatric medication and gained, a tremendous amount of weight, caused, lots of metabolic dysfunction in them. We often see people gain sometimes, unfortunately, 60, 80 pounds from some of these atypical antipsychotics and mood stabilizers that people get put on. And so I think in that context, we're really talking about, improving someone's health span and lifespan tremendously if we can put them on one of those medications and have them lose that weight. And, generally a lot of benefits there. The other context I've used it in is people who are trying to do a ketogenic diet for their mental health condition, but they're just having trouble with intense food cravings. They're having trouble actually being able to do the diet. And so in that context, the idea would be to use a low dose of one of these GLP-1 medications for a temporary period of time as a bridge transition into getting on a ketogenic diet. And then the idea would then to be withdrawing the GLP-1 medication. And so I've seen that work really well in some people too. People just couldn't follow the diet, but then they get on the medication, they follow the diet, we can withdraw the medication in 3 to 6 months after being on the diet. And at that point, their body's adapted to being ketosis. They're lifestyle is adapted to eating those foods, and we do really well at that point.
Yeah. I love that. Yeah. Just, I guess I took this for granted, but for the listener, specific drugs that I was thinking about is metformin, right?
Yeah.
That's been mentioned time and time again, improves insulin sensitivity. A lot of people look at it as a longevity agent, quote unquote. And pioglitazone is the other one. I forgot the mechanism of action for that one specifically, but increases insulin sensitivity again. Those have directly been studied for some of these mental health conditions. And there's, again, a reasonable amount of evidence suggesting that's improvement of symptoms and some of those symptomatic things that you were talking about, Darsh. The GLP-1 thing is really interesting. A lot of people will use the term neuroinflammation.
Right.
I don't really know what that means. Do you?
Yeah. It's just inflammation in the brain, essentially, right? There are markers of inflammation in the brain. And we know that actually a lot of these mental health conditions include a neuroinflammatory component. In fact, there's some studies on depression. If someone they've done studies, a population of people with major depressive disorder and elevated CRP, or highly sensitive C-reactive protein. And they've given those people anti-inflammatories. I think they use celecoxib in those studies. And they've actually reduced depression just with celecoxib in those people, in that population. So, I mean, that really shows that there is an inflammatory component. I think there's actually multiple studies where they've done that.
How long, do you know off the top of your head, how long was that?
I don't remember the time frame. Yeah, I'm sorry to say. I do want to go back to metformin, though. I've prescribed a lot of metformin over the years because that was the drug that we would typically use for people with weight gain and metabolic dysfunction from using atypical antipsychotics. So I've prescribed tons of metformin over the years. And I would say that it's weak in that context in terms of a metabolic improving agent. Even at the highest doses of metformin, we typically don't see a lot of improvement in metabolic markers and weight in that specific population. And I've seen no improvement in mental health from metformin in that population. And so at this point, if someone's gained all that weight and has metabolic dysfunction, I would move more likely towards a GLP-1 medication than that for that context. And I should also say there's some evidence, even though metformin has been studied for longevity, the jury's still out there on longevity, I think. And there are studies that show that metformin has some negative effects on mitochondrial health. And so they take people and put them through an exercise program with metformin and without metformin. And the people with metformin did not get the same mitochondrial improvements as the people without metformin. And so that concerns me. And so if someone is trying to use metformin as a longevity drug, I always cite that study because I think it's enough, at least for me, to say, look, the jury's out on longevity, but we know it's going to have negative effects on your mitochondria. And if you're exercising and trying to do everything you can for your mitochondria, you're actually working against yourself by being on metformin for that reason.
The one case, so coming back to what if somebody's on a ketogenic diet, and is that a time where you'd avoid a GLP-1? Because that could get really tricky, right?
Well, no, that's what I was saying to people who are trying to do a ketogenic diet, but failing because they're having such cravings. That's when I would use a GLP-1 drug to help them transition onto the ketogenic diet on a low dose of a GLP-1 with the express purpose of just transitioning onto the diet and then withdrawing the GLP-1 after 3 to 6 months of someone being on the diet and succeeding on the diet. So I think that's a really important use of GLP-1s for my specific population. People who want to do a ketogenic diet, but are just they have too much food noise. They're on a psychiatric medication that's causing them to have more food noise. They've got relationship to food and sugar that's been going on for many decades that they're having trouble breaking. And so for those folks, sometimes the GLP-1 can help them. They're already motivated to do a ketogenic diet. It'll help them get there. And then we can withdraw the GLP-1.
Love it. Darsh, anything else on here before we switch?
No, I think I'm good here. Yeah, I'm excited for the next subtopic.
Yeah. So as I mentioned, like we were talking about offline, right? So a lot of what we've been talking about is biology-based management, right? And that's kind of what the first part of the discussion was. And I had mentioned to you that Dr. Daniel Amen, I've heard him at least on 2 podcasts, and one recently on the Checkup podcast with Dr. Mike. Was an interesting conversation. We'll link that. He's been an advocate for the past 30 some on years, talking about the importance of brain health. In fact, he wants to get rid of the term mental health. He thinks it's stigmatizing, and maybe that's the case, I suppose. And nobody wants to be called mental. And The interesting about him is that he's scanned the brains of hundreds of thousands of people. And in some sense, he advocates for the importance of getting a SPECT scan. Those who don't know, that's a low dose CT, basically brain CT, that's looking at blood flow and which parts of the brain are lighting up, which are not lighting up, what the implications of that. I'm not really sure. He'll explain that a little bit more. He's written a couple of books about it. And so that begs a question, got me thinking a lot about most of the things with respect to musculoskeletal health, with really a lot of other specialties. We do rely on imaging a lot because we're looking at the anatomy, we're looking at like the physiology with that regard. When it comes to mental health, we haven't really done that. And we've been making this case for biomarkers, for a lot of things that are going to help us improve upon our decision-making process. And I'd love to get your thoughts on that philosophy. Is that something that you use? Do you see there is a role for it now, maybe in the future? Where do you stand on that?
Yeah, it's a great question. Where I would start with that is that a SPECT scan, as you said, is looking at blood flow. And what is blood flow a marker of? But metabolic health, actually. How much blood is going to an area is how metabolically active that area is. And so if we see an area that's either too hot, it's getting too much blood flow, or too cold, it's getting too little blood flow. That's really correlates with hot and cold amounts of metabolic processes, right? I think the utility of SPECT scans for us now, I think, is just not quite there. We just don't have enough data. And I know he's done thousands and thousands, and he thinks that he can help guide treatment. But my sense in really observing the treatment protocols coming out of his clinic is that the SPECT scan doesn't actually guide specific treatments yet. We're just not quite there yet. I wish we could be at a point right now where we could say a specific brain area requires a specific treatment, but the reality is that it's metabolic dysfunction when you see an ugly looking SPECT scan of the brain, and that we need treatments that improve metabolic health, which are the basic things that I'm describing here. And we don't have specific metabolic treatments that target one area of the brain versus a different area of the brain at this point. And so I just don't see the utility of a many $1,000 scan that we can't get insurance to pay for at this point. I hope that at some point we will be at that level of specificity of different brain areas, but I just don't think we're there yet.
Yeah, and I think if anyone chooses to listen to that Dr. Mike episode with Dana Lehman, that was exactly the pushback that he was giving him, was that not enough data, there's no randomized controls trials to figure out what is the threshold for treatment. How do you know how quote unquote sleepy a part of a brain might be? And then I think the protocol that Dana Lehman uses too, it sounded like it was kind of a, hey, here's a bunch of different options. Pick what you kind of want to do. We have TMS, we have exercise, we have some medications, we have supplements as well. And here are the risk and benefits of all of them. Now let you as the patient kind of decide what you want to do. So I'm guessing we don't have like a stringent protocol per se when it comes to understanding, what part of the brain might be quote unquote sleepy or overactive and how to treat that. It's essentially what you're saying as well.
That's essentially what I'm saying. Yeah. And I think if we had, and that's from seeing a number of the reports that have come out of the clinic, and no matter what areas of the brain are lighting up, you almost get a very similar protocol coming out of it. And I also have a pretty similar protocol for almost anyone who comes to me, but I think my protocol gets at a root cause. It's a hard protocol to do. I wouldn't mince words that I'm not asking people to do something. I'm asking people to do something that's challenging, but I also am asking people to do something that I know is going to improve the metabolic health in their brain and therefore improve these symptoms that they're suffering from. So, and regarding, think about these as brain health disorders rather than mental disorders, I'm all for that. But I think I don't want to totally define for people how they want to see their own issue. Some people come in and, they feel like their issue is in something that happened in their childhood. And I don't want to take that away from someone. But what I will say is that probably is having effects on your brain that include metabolic effects on your brain. We know that adverse childhood events are highly correlated to later on mental health disorders, but also correlated with metabolic health disorders. So we know just how important the metabolic piece is. But I also think that people really want to, and I think they deserve the right to define their own suffering in the way that helps them, and is less stigmatizing to them. So for some people, calling it a brain health disorder is less stigmatizing. For other people, that's more stigmatizing. So I think we just have to be careful with our language depending on who we're talking to.
How expensive is the spec?
I don't know for sure, but I think it's quite pricey, a brain spec. Yeah.
Because I guess I related to like the full body MRIs that people can now choose to get. Are you opposed to people going out? Let's say they have the money, they want to get a scan of their brain or a scan of their body. Are you opposed to that type of imaging, or do you just let people kind of choose to guide their own?
I don't have people. I don't meet people who are going out and getting a bunch of spec scans very often. I think Dr. Amen's clinics are one of the few that are really trying to promote spec scans of the brain as a tool for helping people with these types of conditions or symptoms. I don't see it as something that people are otherwise promoting that much. I think there's a lot of companies that might promote like full body MRIs, for example, but I don't think there are that many that are promoting spec scans. And I don't know of any psychiatric providers who are ordering spec scans routinely on people, unless they have a spec scan as part of their protocol and part of their clinic.
Yeah. What about functional MRI? Same thing?
Same thing. Yeah. Functional MRI is a research tool at this point. We're not using functional MRI in diagnosis or clinically at all at this point.
Awesome. So let's see if we could kind of put this all together, right? For somebody who might be
let me just reverse what I just said a little bit, in that there is one protocol that uses functional MRI, which is there's a TMS protocol that was developed at Stanford called the SAINT protocol. And in that protocol, they do use functional MRI to try to figure out which areas of the brain to target with the TMS. And then, so in that protocol, and that protocol has been shown to be very effective in treatment-resistant depression. However, there are other protocols that also do an accelerated version of TMS, like that SAINT protocol does, which is really like, it's about 12 weeks of TMS in a week. So you're really doing TMS all day long for 5 days. And there's other protocols that don't use a functional MRI that also get really good results in treatment-resistant depression. And so it's a little unclear to me how important the functional MRI is. Those other protocols, my understanding is they're using the TMS machine to map the brain a little bit and just to find out where the magnets should be placed. And my understanding is that those are also quite effective in treatment-resistant depression. And I've seen them be quite effective without using the functional MRI. So it's part of that SAINT protocol, but that's kind of the one place where it's used clinically that I know of at this point.
Love it. So I'm hoping that some general practitioners, primary care physicians are going to be listening to this, maybe even some psychiatrists. And they're hearing this, they're thinking, cool, but I don't run a metabolic clinic. Right. Not to mention, I don't have time to sit here and have deep discussions about understanding people's lifestyle and what type of nutrition they're on. And maybe there's a strong knowledge gap. Again, we've talked about this time and again, this is not something we spend time in medical school learning.
Right.
Hopefully, if they're listening to this podcast, we're filling that knowledge gap for them. But for that person who's listening, what are something that you could say next week? What are 3 things that they can start on? What are some baseline labs that should be non-negotiable before or during psych meds? What are some key questions that they should be asking to distill down the understanding of what this person's metabolic health might be? What are some actionable things you could say for them?
Yeah. So I think you're right that this is not necessarily an easy thing to replicate in a primary care visit that's 5 or 10 minutes, or even in a psychiatric visit that might be 15 minutes or even 25 minutes. But there are some things that people can do. So I think before starting these psychiatric meds that have metabolic consequences, we want to get a baseline level of someone's metabolic health. We want to get a lipid panel. We want to get an HbA1c. We want to get a home IR. Home IRs, I think I maybe said this before, but should be part of an annual physical for every single person, which it's actually boggles my mind that we don't have that as part of an annual physical. We're just waiting for the HbA1c to go up. That doesn't make a lot of sense from a preventative point of view, because we can see alterations in the home IR 10 to 15 years before the HbA1c moves. So we really would want to see that. I think getting full thyroid panel can be really helpful. I always get a vitamin D level. These are all things that are just B12 level. These are just some basic things that a psychiatrist would want to know to really rule out if there's some kind of underlying metabolic or medical condition before starting a psychiatric medication. And then getting a sense of just, does the person exercise? If not, can you get them to exercise? Some of these problems, as we said, can really be amenable to exercise. And it's not just as little as, please just go exercise. Like, we really have to use our skills, especially psychiatrists. We've been trained to work on motivation and underlying resistances. We should be using those skills for getting people to do things that are good for their mental and physical health. So I would say that's one that I strongly believe in. And sometimes, even before I started talking about ketogenic diets, I felt like for years I was spending half my day talking to people about exercise for their mental health. And there's just incredible benefits for that.
What about in the inpatient setting? Are there any tips and tricks like that you could provide me as an inpatient rehab doc to try and get my patients set up in a way that when they get home, they can at least take that lifestyle? Because again, offline, we talked about how I had a patient with functional neurological disorder, otherwise known as conversion disorder in the past. And, as you said, they don't really see psychiatrists, but we're at least sending him to a neuropsychologist to get in-depth testing. But I didn't have an insulin resistance that I could check. I do try very, very hard with all my patients, try and simulate a lifestyle medicine type environment for them. They're already doing the PTOT, doing the exercises. Sleep, I try not to disturb them. And I told it to be a low stimulation environment. Diet, you can only control so much there, but at least you can educate. Any other tips and tricks from your end, though? How do I get somebody maybe set up with a metabolic psychiatrist after?
Well, there aren't that many metabolic psychiatrists, unfortunately, yet. Hopefully we'll be changing that. But there are some online programs that are focusing on metabolic and mental health now that people can start accessing. And I could get you some of those links if you want to put them in the show notes, some of those programs. And I think just really emphasizing how important this is. You're having these issues with your mental health. This is not something that you only want to focus on a medication for. I mean, maybe a medication could be part of it. Maybe psychotherapy could be part of it, but really making that connection for people between their physical health, their body, and their brain. This is where all this is coming from. It's not just up above the neck, which is unfortunately where we've thought about all these things originating for so many years now. That's kind of how everyone thinks about them. And so I think we have to, as the physician in the room, you got to change people's thinking that this is not just about what's going on in your brain and in your mind. This is connected to what's going on in your body, which is connected to your movement, to your food, to your sleep, to your light. All of that's important.
Yeah, absolutely. Well, Matt, we just want to say thanks so much for being gracious with your time. I mean, this is why we love doing this podcast. Everything we talked about was so actionable. I think the audience is just going to take away a lot of nuance away from it too, and kind of take some application and adjust their lifestyles. I'm definitely going to get back to the fasting. So I definitely appreciate your time. Before we let you go, tell us where our audience can find you, where they can connect with you, and maybe what's next for you.
Sure. So, people can find the program I was talking about, Accord, at www.accordmh.com, accordmh.com, ACCORDMH. And then people can find me on LinkedIn. I don't do a lot of social media, but I do have a LinkedIn profile. So if anyone wanted to connect with me individually and just had a question, or they wanted to just connect, they can find me on LinkedIn. And I like to respond to people who've got any kind of specific question about any of these topics. So those are some places to find me. In terms of what's next, I'm hoping to expand metabolic psychiatry offerings for people and just really try to create more options for people to access this incredibly effective treatment to get the support they need to be able to do that.
Awesome. Love it. Last question we have for you, Matt. How do we put the health back in healthcare?
Wow. Yeah.
And 4 years, another hour.
Yeah. I mean, it's a great question because it gets at this problem we have, which is that we are doing sick care in modern medicine now, not healthcare. And so it's really talking about the things we've been talking about today. It's talking about diet and exercise and light and sleep, because that's how health is created. And in fact, even that's how mental health problems can be reversed. So not only creation of health, but reversal of problems all comes from that. So I think that's where we want to be thinking. We want to be thinking about things that, what were our ancestors doing? And I don't mean like 100 years ago. I'm talking about 10,000 years ago, before agriculture. How were they living and how did they create health? We know that they were pretty robust back then, and they actually had bigger brains than we do now, actually. And, one of the ways they did that is they were moving all the time to find their food. They were fasting all the time because they couldn't find food. And they weren't eating a whole bunch of processed food at all. They weren't eating sugar very often, and they were certainly not eating carbohydrates. So if we kind of mimic that, and they were outside a lot, they were getting light all the time. So if we mimic a little bit of that, as much of that as we can mimic in our modern lifestyle, the better off we're going to be.
Awesome. Appreciate it, Matt. Thank you.
Yeah.
Thanks, Matt.
My pleasure. Thank you.
Thanks for listening to another episode of Medicine Redefined. If you enjoyed this episode, please be sure to check out some of the additional resources in the show notes. Please also check out our social media platforms where you can find more content like this. You can follow us on Instagram, Twitter, and TikTok at MedRedefined. We also want to thank our team for the production of this podcast, specifically Ethan Ju on video, Harita Yepuri on social media, Zainab Lugmani on research, and Sarah Khan for newsletter. Oh, and if you want to get similar bite-sized information delivered to your inbox every Sunday, please be sure to sign up for our newsletter. Also, if you enjoyed the show, please be sure to subscribe, review, and share with anyone who you think will gain value from this as well. Now, time for the ever so important disclaimers. This podcast is intended for general public use and is for educational purposes only. It does not constitute the practice of medicine, nor should it be construed as medical advice. No physician-patient relationship is formed, and anything discussed in this podcast does not represent the views of our employers. We recommend that you seek the guidance of your personal physician regarding any specific health-related issues.